Welcome back to the Emergency Medical Channel. I am Divya Rajan, a 4th year medical student, and this is Baiju, who has volunteered to be our patient today for our respiratory system examination. So firstly, we have to start with the history, a generalized history, and after finding out that the pathology is in the respiratory system, we will take the consent of the patient if he is comfortable with the respiratory examination. Normally, the examination should be done without any clothes on, but due to the patient's comfort, we are keeping the clothes on. Now, starting with the general examination. Starting with the general examination, usually in general examination, the things that will be positive are cyanosis at the tip of the tongue, at the tip of the fingers.
So you have to see the hands and tongue to see whether the patient is cyanotic or not.
And you can also see clubbing.
Or fingertips, you have to see whether it is bulged or not.
Yes. And cervical lymphadenopathy.
Mostly cervical and axillary we have to see, because cervical it drains all lungs and axillary it drains the pleura.
Yes. After that, we can start with the respiratory examination. There are 4 components of the respiratory examination. There is inspection, palpation, percussion, and auscultation. So first, starting with inspection. First, we have to inspect if the trachea is central or not. So
you can see the trachea.
If it's central or not.
So trachea is central. You can see the sternocleidomastoid.
Now we will check if this chest is bilaterally symmetrical. Next, we have to check for chest movements, whether there is equal chest movements on both sides. Then we can overall inspect if there is any skeletal deformities or scars. Then we have to inspect the apical impulse. That will usually be in the left 5th intercostal space at the midclavicular line.
So all these things are done, like whether it's the movement or apical impulse, all these things are done to see whether the mediastinum is shifted to one side, or if suppose there is a lesion on the right side in the leg, so movement can be naturally reduced. That's why we are checking all these things.
Next, we will turn the patient towards the back.
Back, full light.
And now we should inspect if there is any drooping of shoulders there or not there. Next, again in the front. Can you turn in the front? Check if there is like intercostal, any hollowing in the spaces, in the rib spaces.
So any intercostal indrawing is there or not? Normally in asthma, COPD, when the patient is breathing tightly, you can see intercostal indrawing happens. Or there are some condition, lung volume loss condition, there also you can see one-sided intercostal indrawing. But normally what clinical practice, what you see is the accessory muscles, that is intercostal muscles, are highly active, so you can visibly see the intercostal indrawing.
Next, we will inspect the sternum and the spine. Sternum, if it is hollowed, then it is pectus excavatum, and if it is bulged out, it's pectus carinatum.
So these things are very important, because when there is an pectus excavatum, lungs can be slightly displaced to one side or backwards. So these things may slightly alter your examination finding. So you can explain all these things. Or there are some other conditions, bone lesions or bone diseases, where you get a pectus carinatum.
Then we will check the spine, if there is any kyphosis or scoliosis present.
So during the examination of spine, normally what in MBBS what we don't learn is to check for the pain in that pain or tenderness in the sternum or spine or ribs. That is very important, because there are some conditions like malignancy, you get rib pains. So due to that, patient will get breathlessness or pain during breathing. So that also during examination you can just see and skip.
Yes. Then next we can go to palpation. In palpation, first we have to check with the dorsum of the hand if there is any local rise of temperature in any region of the chest. Then check for any tenderness if it is present.
Any bony tenderness.
Now then we have to check for respiratory movements in palpation. Now first initially.
So before that you have to check your whatever you have seen, this trachea. You have to confirm your finding.
So we have to put our hands at the sternoclavicular joint and then run our middle finger down to check if the trachea.
And press on the both sides of trachea and see whether trachea is deviated to one side or not.
Next, for respiratory movements, if we turn the patient around, we can see totally turn. Here, when you take a deep breath, Here, her hands should move up
Okay.
and my thumbs should move laterally.
So there are two important movements here. You are keeping on the shoulder. So one is up and
Up.
down. Okay, up and down. You can see. Other one is expansion. Expansion. Ideally, you have to check here.
Yes.
Here there will not be expansion. Here only up and down
Up
will
and
be. Okay.
And here, here you can check expansion.
Okay.
When he
So
takes
keep
a
it
deep
like
breath.
this. So you can see that. Vaiju neeti shasam valgu. So you can see now it is
Yes.
expanding. Okay. So that finding. Suppose there is lesion on right side. That side movement will be reduced. Anteriorly, how we check?
Anteriorly,
Padukadina.
tirichu. Anteriorly, we keep our hands like this.
Okay.
And
Okay.
then we have to shwasam and here, like
Okay,
it will
so
move
it is
like
move. It is called as bucket handle movement.
Bucket
Handle will move upwards on the top, and anteriorly it moves like this. Posteriorly it moves like this. So that is called as bucket handle movement. What we learn in physiology. Okay, so all sides should be equally moving. That's what we are expecting in a normal patient. Okay.
Yes. Now, if the pathology is usually in the front of the
Okay.
chest, then it's usually the upper lobe.
Okay.
If it's in the back, it's the
Okay.
lower lobe.
Okay,
And
that,
the
so
axis.
predominantly backside is lower lobe.
Lower lobe.
Okay, what we think normally is they were there also upper lobe, middle lobe, lower lobe, but it is not like that. Posteriorly, everything is lower lobe. Anteriorly, it is predominantly upper lobe. Okay.
And axilla, it can be any of the three.
Okay, any three lobes can be on right side, any two lobes can be on the left side. Okay.
Now we will check the diameters.
Okay.
So for the diameters, first we will check the entire circumference of the
Okay.
chest.
Okay.
For this, we have to keep it at the level of the nipples
Okay.
in the front.
Okay.
Check
Some
out
books
kite.
does not allow that. Some books says that you have to go for a bony prominence in the chest.
Okay.
But for practical purpose in male patient, nipple is okay.
Nipples in the front and T7 at the back.
Okay. Okay.
T7 at the back.
Okay. So why some books does not, some guideline does not allow it, some patients can have gynecomastia.
Yes,
So it will be drooping. So they ask for a fourth intercostal rib or fourth rib or something in the anterior. Okay.
Now we tell him to take a deep breath.
Vaiju Shasana Niti Varikku, patient is taking a deep breath.
And then the expansion should be minimum of 2 centimeters.
Okay. So if there is no major lung lesion, expansion will be good. Suppose there is a severely restricted lung. Okay. Even externally, like a thick skin can also reduce the movement. Okay. Anyway, you have to document the total movement and hemithorax.
Hemithorax. Hemithorax is at the midpoint of the anterior.
Okay. Kai pokki vidichu.
In the middle of the anterior part and the middle of the posterior chest wall. And again, we'll for both the sides we have to
Yes, you have to check the opposite side.
Opposite
Okay,
side also.
correct.
Now we'll check the AP and transverse diameter.
Okay.
കുറച്ച് ഇവിടെ.
Correct ആയിട്ട് പിടിച്ചോ.
Here and here.
Okay, so two books are kept or two pads are kept like this, and you have to take the measurement. So this
And we
is
have to check that this is the transverse
Transverse.
diameter around
Okay.
20.
okay.
And then we keep the books
Okay.
like this and check the antero-posterior diameter.
Okay.
Now
So-
normally the transverse should be greater than the
More than
antero-posterior.
transverse is more than the
Anterior.
AP. Which condition you get reverse? Like reverse means transverse diameter will be more or equal to AP.
That is in barrel shaped chest
Barrel
like
shape.
COPD.
Okay, AP diameter will be slightly more than the normal.
Normal.
Okay, it will become like a barrel. It is classical finding of
Asthma or emphysema.
COPD. It is a classical finding of COPD. But remember, in pectus excavatum also, you can get something like this. So that's why I told initially there are some physiological variants can alter your clinical diagnosis. Okay.
Now next we can go to percussion.
Okay.
Percussion, now we have to first percuss the anterior chest wall.
Okay.
Now here first the areas are the supraclavicular, clavicular, infraclavicular, mammary and inframammary.
Yes, correct.
Now in mammary and inframammary there is first, second, third, fourth and fifth
Okay.
and sixth.
So some books does not say mammary and inframammary.
Okay.
They just say infraclavicular and mammary.
Yeah.
So, but to avoid that confusion, you can just tell second space, third space, fourth space. Like that also possible. We just want to know where is the lesion. That's all. Okay. You can percuss in the supraclavicular area.
So supraclavicular you put our
So you have to use the middle finger.
and use our wrist movement.
So only wrist should be moving like this, not the hand. Okay.
Then for clavicle we have to stretch the skin.
Okay.
And at the medial 1/3 and lateral to the junction
Middle. Okay.
we have to
Okay.
percuss.
Okay.
Similarly, like that, we have to percuss till we go
Okay.
to the sixth
Okay.
space.
Okay.
When we reach the sixth space, there is a dullness there.
Okay. That is
Liver. dull.
liver dullness. Then you ask the patient to take a deep breath so that it will go down. Suppose that is not going down. So you are getting liver dullness and you ask the patient to take a deep breath. It is not going down. Patient is having fever, chills, rigors. What will you suspect?
We'll suspect if it's shifting dullness, and it will suspect below the
Below the
diaphragm.
diaphragm. If it is not shifting, then it is mostly above the
Above the
diaphragm. It can be tumor, it can be pneumonia,
Pneumonia,
it can be
consolidation.
even pleural effusion also. Okay. So that is the importance of liver dullness. Then
Yes.
opposite side.
Next, opposite side also we have to
So
do the
ideally, always remember like this: you are percussing supraclavicular notch in the right side. Immediately you go to the left side, then clavicular right, clavicular left, not like this. Okay. Ideal method is compare both sides. Okay.
next we can go to the
Now
axillary.
here, what is the difference between?
Here on the left side there will be cardiac dullness.
So you don't get any resonant node there. Only in the second space you get resonance. Suppose in a patient with pulmonary hypertension, that can be slightly dull. Okay. So that is anterior percussion. Then
Now axilla.
how do you percuss axilla?
Axilla, we will tell the patient to keep the hand
By
on
ഇങ്ങനെ
the
വെക്കണം
head.
തലേൻ്റെ മുകളിൽ രണ്ട്
Like
കൈ.
this.
Okay. So that is the ideal position.
Yes.
Okay.
And then axillary and then infraaxillary.
Okay. Axillary and infraaxillary. So like that, axillary percuss here, then axillary on the
Axillary
opposite
percuss.
side, infraaxillary on that side, infraaxillary on this side. Then posterior. Okay. ഇനി ബൈജു ഇങ്ങോട്ട് ടേൺ ചെയ്യണം. ഇങ്ങോട്ട് ഫുള്ളായിട്ട് എടുത്തിരുന്നു ബാക്കോട്ട് തിന്നു. So how do you percuss in the posterior part?
Posterior part, now we'll do first
No,
supra.
no, before that, what should be the
First
position?
we have to keep the patient's hands
ബൈജു
like
ഇങ്ങനെ
this.
വെക്കണം. So
So the
that is very
space
important.
will be-
So you get a space here. Okay.
Then suprascapular on this
Okay.
side and on this side.
Okay.
Then interscapular
Okay.
on both the sides.
Okay.
And then infrascapular.
Okay. 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 So you know now how like what is a method to percuss? What are the various types of percussion notes? So
Right.
normally when I am percussing on the right side, I get a note, percussion note. What is that?
Resonant
It is resonant because lung contains air. That's why it is resonant. When I percuss on the heart, what note do you get?
dull.
It is dull because it is water. That's why it is dull. Suppose you percuss on the table, what type of note you will get?
will
It is
get-
almost resonant to dull, mildly dull. But if you percuss on the wall, what you get? It will be stony dull.
Stony
Okay.
dull.
Pleural effusions are always stony dull. But whereas a pneumonia, consolidation, or a tumor, that will be impaired. Okay, so you should understand the difference between resonant, impaired, and dull. Resonant is it contains air. It is replaced by solid, but it is not water. Then you get a impaired, like something like you percuss on the table. Okay, but when you are percussing on the water, that is pure effusion, it will be stony dullness. Okay, so that is about dullness. Sorry, percussion notes.
Percussion.
Okay, then now next is
Next we'll go to auscultation.
auscultation.
Auscultation, initially, now we have to use our step, where initially we have to first check the trachea.
So you are taking, you are seeing the trachea for.
Bronchial
So you
breath sound.
just wanted to know what is the actual bronchial breath sound. So whenever you are auscultating in a trachea in a normal person, what you are hearing is a bronchial breath sound. Bronchial breath sound is a high pitched, high quality sound, and there will be some gap in between inspiration and expiration. Expiration also prolonged. Okay, so that is bronchial breath sound. So that is high pitched, gap between inspiration and expiration. Expiration is prolonged. That is a bronchial breath sound. What you auscultate here next is
Here we'll hear vesicular breath
vesicular. So what is the difference between this and this? The pitch has come down. From that high pitch, it has come down to a normal pitch or a low pitch. But what will happen to the middle part? Middle part is attenuated.
sound. Okay.
The last part of the expiration is filtered off. This is called as filtration and attenuation effect of your lung. Okay. So auscultate all the areas.
Now same areas which we percuss.
Okay.
The supraclavicular,
Okay.
clavicular,
Okay.
infraclavicular.
So clavicular normally we cannot auscultate. You get only scratching sound. So we can just avoid it. But all other areas you have to auscultate. Okay. Normally you get a vesicular breath sound. Okay. But there are some conditions like pneumonia, consolidation. What changes can happen on auscultation?
On auscultation in pneumonia, instead of getting vesicular breath sounds here, you will get bronchial breath.
So you have a consolidation. Consolidation means lung tissues replaced by a solid structure. Okay, so always you should understand that solid structures are good conductors of sound. So whatever produced in your bronchial, like in trachea, that is bronchial breath sound. When it is going to your trachea and your bronchus, it's going to a pneumonia, consolidation here. When you are auscultating here, whatever you are hearing, you can hear also. Okay, that is because the solids are good conductors of sound. Whereas suppose you get a pleural effusion, what will happen? Pleural effusion, what will happen?
Pleural effusion, you won't get same vesicular breath sound.
You get vesicular breath sound, but it is completely reduced. So pleural effusion can mask the sound, it can reduce the sound. Fluids are not good conductors of sound. So you can get vesicular breath sound, but it is very, very minimal. Whereas in a fibrotic band, lot of fibrosis is there. What sound you get? You get crepitation. So in pneumonia, later phase of pneumonia, fibrosis, or any fibrothorax, everywhere you get crepitation. Whereas in pleural effusion, you get reduced breath sound. Consolidation, you get bronchial breath sound. Tumor, you can get again bronchial breath sound. But what you should understand is whether it is a tumor or consolidation, your main bronchus is blocked, then there also you get absent breath sounds. So that is normal vesicular breath sound. Now, what are the other things you have to check in auscultation?
Then we have to check for vocal fremitus.
So what is that?
Vocal fremitus, what we have to take vocal fremitus and vocal resonance.
Okay.
Here we should use our ulnar border.
Okay.
And check for, and first using ulnar border because of the frequency.
Okay. So that actually comes under inspection, but when you are examining, in a routine case, vocal fremitus, vocal resonance come together. But in a examination, like a practical examination, this has to go in inspection side, and with stethoscope it has to come in auscultation side. Okay, but both are same. So how do you check it?
Here you ask the patient to say one.
Again, you just keep your hand here, hand in the trachea, and ask him to tell one.
Yeah.
So what is the feeling?
You can feel like
it is
a vibe.
Increased.
Yes.
Okay. Now you keep it here. So what is that? It is reduced. So this is a high pitch sound. That's why you are getting more. So same like that. Suppose you have a major large cavity or large pneumonia consolidation. Again, whatever sound you are getting here, that same sound will be heard over there also. Like that, you can use your stethoscope also. Use your stethoscope.
That is for vocal resonance.
Okay.
Vocal resonance, we will check. Tell him to say one.
So you are feeling that sound. Now auscultate here. Okay.
It's less.
So it is less. Here it is more. So, okay. So in trachea you are getting bronchial breath sound. You are getting vocal resonance and vocal what is it?
Fremitus.
Fremitus. Both are increased. Okay. So suppose you have a pneumonia here, same things happen there also. Okay. So that is a difference. Okay. Next is what?
Next, after auscultatory findings, after we confirm that whether it is, sometimes vocal resonance will increase or decrease, as you said.
Okay.
In case of consolidation, it will increase, and in case of pleural effusion, decrease.
Okay.
Based on that, we can diagnose what is the respiratory.
Okay. So some few scenarios I'll just tell you. You have an asthma case, you have a COPD case. How do you differentiate all these things?
In asthma case, first of all, about the risk factors and when it will occur.
Okay, allergy, risk factors, family history are very important. Whereas in COPD?
In COPD, it will be smoking.
Smoking history is very important. Age, it is, asthma is younger age group. COPD is? Older age group. History of smoking is more in? Emphysema or COPD. Then, major thing is, the progression of the disease. Asthma, it is intermittent. Sometimes patient will have symptoms, sometimes he will be absolutely normal. Whereas COPD
continuous.
Is throughout the year he will have cough, breathlessness, and in between he get acute exacerbation. Then if you do a PFT, pulmonary function test, what will be there?
It will improve in asthma.
Asthma, after nebulization you can see 15% improvement in the FEV1. Whereas in COPD, that much improvement cannot be there. Okay, so that is asthma and COPD. What are the clinical findings of pleural effusion?
Pleural effusion on percussion will be stony.
First, you see that side of the chest will be
trachea also will be deviated to the opposite side.
Trachea will be pushed to opposite side. Then
chest movements will be reduced on that side. Then there will be the diameter also.
Diameter can sometimes increase. Significant pleural effusion can increase.
Then on percussion, stony
Stony
dullness.
dullness. Auscultation,
Auscultation, the vocal frequency and resonance will decrease.
everything will reduce. Whereas in pneumothorax,
Pneumothorax, again the trachea again will be deviated to opposite
trachea
side.
deviated to opposite side.
The chest movements again reduced on
Chest
that
movements
side.
are reduced.
Uh,
Percussion,
Percussion, it will be hyper
it is hyper resonant. Then
and then a vocal resonance and vocal frequencies will
will it's a air is not a good conductor of sound.
So it
Like
will
your
decrease.
water, air is also not a good conductor of sound. So everything will come down. All your respiratory sounds will come down. Only thing what a clinical like MBBS student should know is once you diagnose pneumothorax or once you get a feeling of pneumothorax, you are not examine in detail the patient. If the patient is in distress, you have to treat it fast, or you just take an X-ray if possible. Percussion, all these things can sometimes aggravate the problem. Okay, suppose you have a tumor on the right side. Tumor, what findings you can get?
tumor or consolidation. The
Consolidation is different.
Tumor, there will be when you're doing auscultation findings.
Tumor normally a tumor drags the trachea towards it, or
Same side, yes.
tumor drags the mediastinum towards it. So trachea will be deviated to the same side. Then auscultation, what do you get?
Auscultation for the vesicular sound, instead of vesicular you will hear bronchial.
So you can get a bronchial breath sound because it's a tumor. It's a solid structure. Only thing, suppose the major bronchus is obstructed by lymph nodes or something, you can get absent breath sounds. Fibrosis, cavity and all.
Cavity and all also they will be.
So trachea will be deviated to
the same side, and on auscultation again instead
you
of.
can get lot of crepitation. Sometimes you get bronchial breath sound, or sometimes you can get cavernous breath sound. Okay, cavernous is a type of bronchial breath sound, but it is still higher pitch. Nowadays we don't see all these things because the amount of tuberculosis is coming down. Okay, but that also you can get. Okay, so these are the common scenarios an MBBS student should know. Okay, so we have discussed most of the thing. Vaiju, thank you.
Thank you.
Welcome.
Okay.